Congratulations on Donna's big promotion. Donna, let's shut up for Donna. So they didn't know, or they didn't actually trust the fact that I would be here, Jane and Donna. So they actually made a video. I don't know where that video is. So it's also nice to see Dave Sheehan there as well. Everybody knows that Dave is actually the force behind this whole thing from the physician side, and we're glad to have him. I think he's going to be enshrined on Mount Rushmore. But I thought I would actually come up here, or down here, I suppose, from Philadelphia, because I actually think this whole business, or as Bill Norwood used to say, this whole bit, is a lot more important than maybe it even used to be. And the reason why I say that is just a couple weeks ago, I was sitting in my office and I got a couple of phone calls, completely out of the blue and very close to each other, maybe a couple hours with each other. One was from the president of the Neurosurgical Association, the other was from the president of the ENT Association. Now, as it turns out, these two associations, you might think that they would have data. They're big, powerful organizations that do important stuff, but they have nothing, zero. And so they basically wanted to ask, well, what do you guys do at STS? How did you do this? Can we come to Chicago and help and figure it out? Can we meet Donna and Dave Sheehan and Jane Hahn and all these people? And so it was very interesting, and I think that one of the reasons why this is happening is because in Washington, D.C., and in the CEO suites of most health systems in the United States, data is king, and the whole bit about value, healthcare value, is outcomes, is finances and outcomes. But it's not just finances alone. You can't compute the concept of value in healthcare without having outcomes. So I think this is the reason why all of you and those of us, for example, the STS, are suddenly a little bit more elevated within the halls of the healthcare environment. So what do I do here? Forward. So this is what I was just talking about, the importance of our database managers, which is you, is that the entire value proposition of healthcare really resides with you all. And none of this value concept is even alive unless it's dead on arrival, unless we have the data. And it has to be good clinical data. It can't be claims data, administrative data. For example, I was just in a meeting the other day regarding, and there was a bunch of people, and we had, and I just asked a simple question, who were the surgeons? And this is from administrative claims data, and the anesthesiologist was 2% of the time they had the anesthesiologist as the surgeon. A couple times they had the referring cardiologist as the surgeon. So the administrative databases are basically not detailed enough and deep enough for real good outcomes reporting. The database growth for all of you has been pretty amazing. If you look at the adult cardiac surgery participation, which is ranked between 1,000 and 1,050, is 1,100, is flat. And the reason why it's flat is because almost, I think maybe Dave will be telling you this, he can correct me if I'm wrong, but somewhere around 95% of all general cardiac surgical cases are captured in the adult cardiac surgery database. And there's a number of programs that are in the federal system or in the VA system that are not part of the database. So that's going to be flat because basically it's 100% or near 100% of penetrance. There's the general thoracic growth and the congenital heart surgery growth, and obviously we have some very significant kind of movements in congenital, which will be talked about over the next day or two. This is the STS National Database participants in the adult side, adult cardiac. What's interesting about this is it gives you numbers, and you see obviously California and Texas have a lot, Pennsylvania, Ohio, and Illinois, New York. It's interesting, you look at Pennsylvania and New York, and there's twice as many programs in Pennsylvania as New York. That's the difference between a CON state and a non-CON state, just to let you know what that means. But what's more important than these numbers actually is the percentage of each state that's STS database participants. And for example, I know Massachusetts and Pennsylvania, 100% of every program in those two states anyway are in the STS national database. General thoracic, here's the national map for general thoracic. The general thoracic database is growing, as you saw, and is getting more and more depth as far as our penetrance, as far as we see in the country. There is a little bit of competition, you might say, in the sense that there's a certain amount of general thoracic surgery done by general surgeons. So some of this is with the American College of Surgeons databases. But we're very, very proud of the general thoracic database that continues to improve and have more penetrance each year. And then the congenital database, as you can see here, this is the national map of the congenital databases. And most of the congenital heart surgery programs in the United States are part of the congenital database. And in some states now, there's consortiums regarding public reporting at the state level that are using STS database by law. An example of those, one of those is Pennsylvania. So the key and the reason why the president of the Neurosurgical Association, the president of the ENT Association, etc., have given us a call is because of this slide. The fact of the matter is that the data that's coming out of the STS database regarding quality is working, and we have a continuous quality improvement situation. And this is just looking at about a 15-year snapshot, and you can see that the STS adult cardiac surgery database regarding the 7 major operations and categories that we do, we're getting better and better and better. So you can see that the results, and frankly, I think most of these results are a result of continuous quality improvement related to data from the STS database. And for example, even in our own shop, and I've spoken to Dave about this, and this is one area where we have a little bit of a boxing match, but we were having a problem with our 24-hour, with our intubation times, and especially in one category, which was the AVR cabbage. So we were just really upset about this, and we went to the drawing boards about a year ago, 12 months ago, and sat everybody down, because in that case you have to sit down the anesthesiologist and nursing staff as well. And we really, really turned it around. And it was all completely a result of the STS national database, and our quality got a lot better. And this is just at my own hospital. So that's, now and this is the example I was just trying to show you. This is just personal, that we use this data, and I think every cardiac surgeon in the United States uses this data every single day or every week, every month, to improve their results. Frankly, the public reporting issues, and we'll get to that in a second, are even going to make this more accelerated. And maybe, because one of the things that some people have taught me is that it's not about the money, it's about the money, And so the fact of the matter is, when the federal government and the insurance companies are all getting into the value proposition, then it's even going to be more accelerated as far as getting good data. So, as everybody knows in this room, we've had some significant public reporting is a very, very significant part of the new approach to data. And this is not just for the STS database, but also for NCDR and cardiology and other databases. And in this particular case, as you see on the slide, for the UK. And this was about almost 15 or 20 years ago, where this congenital heart group in Bristol, UK, had some more mortalities than they should have, and they basically got on the worst thing possible, which is the front pages of the Daily Mirror, and this ended up causing a big scandal. And we've seen this here in the United States as well, in some other places around the country regarding quality of congenital, and also quality, of course, of adult cardiac and general thoracic as well. But what happened with this is very interesting, is that the public reporting, which we're getting into, and David and Donna can talk to you about the exact penetrance, somewhere around 50, a little bit over 50% for adult cardiac, and upwards of 60 to 65% maybe for the congenital groups for public reporting in the United States. But this started public reporting in UK, and actually made a big, big difference in how UK administers their congenital heart surgery care in that whole country. And so my only point of showing the slide is how important this dotted lines are between what you do as data managers, getting the data for us in the STS National Database, and then having it go to the next level, which is public reporting. And then you have major, major changes in the healthcare delivery systems. General thoracic has also done very well. These are the discharge mortality rates for all patients over about 10 years or so. And you can see that the quality is getting better and better and better in the United States. I might say another thing about Europe, say, versus what Donna didn't tell you is I'm an American who grew up most of my life in Europe, so I kind of hit those guys. When we go to these multi-continental meetings, especially regarding some trials, it's very interesting to me that the American data for the same exact operation, both places have smart people. Our data is a little better. Our results are a little better. Our quality is a little bit better. Why is that? I think it's because of you guys. I think it's because of the STS database is pressing us. It's also maybe a little bit about public reporting. And it could be because of the trial lawyers too, but I don't want to give them any credit. So anyway, the discharge mortality rates for general thoracic have improved dramatically, and I think that will continue as we get better and better with our database of general thoracic, and have a higher penetrance of thoracic surgical procedures being done by board-certified thoracic surgeons. The STS congenital heart database, this is discharge mortality rates for patients in congenital heart disease across the country. You can see they're improving as well over the past 15 years, and there's been some really dramatic improvements here in the congenital space. So I know that there are some challenges for all you, and sometimes you have to almost go back to Einstein. Okay, so Einstein said, one of his great lines was, make it as simple as possible. And everybody knows that line, it's a very common line. Make it as simple as possible. But everybody forgets the second sentence in that line, which was, but no simpler. Okay, but no simpler. So, make it as simple as possible, but no simpler. Well, that's what we have here. We want to make everything as simple as possible, but we don't make it so simple that it's all dumb. Okay, so the data collection burden is significant. We know that. We know that there's a significant quantity. You can yell at Dave and Donna and Jane about that, okay, and see if we can make it a little bit simpler. But it is complex stuff, and it is very important. For example, maybe, and I'm just throwing this out there because we're going to have this new aortic. I've been told that I cannot use the word module, but it seems like it's a section. Module has a certain word here, but certain meaning. But we may have to have, the PAs or the cardiac surgeons themselves, be beaten up to put this data in, some of the data, especially the intraoperative data, in for themselves, and we need to maybe recruit them, and that's just an example. We understand that EHRs are not interoperable, and that we have significant issues with EHRs, and some stuff's bigger than even all of us, and the whole EHR situation is bigger than you and me. But we're going to have to try to work with that whole situation as it's phased in over the next few years. We know that there are limited hospital resources, that the finances are ratcheting up and tightening up. But I just want you to know that at our level, at the STS leadership, we're being fairly draconian and a little bit harsh with some of our partners from the healthcare industry, in the sense that we're being very determined to talk to the hospital CEOs, to speak to the health systems in Washington, D.C. as well, to demonstrate the importance of quality data, the data that the data managers get for the STS database. Again, this is the reason why the presidents of all these other societies are calling us out, is that this is very, very important, and we can't have a limited resource environment at our major health systems in the United States. So I just want you to know that we're kind of working on your behalf behind the scenes, and being a little bit of a pain in the neck. So we know that data managers play a crucial role in improving outcomes, that we have data-driven reimbursement coming up. Again, that whole value concept I just talked about. You know, there is another side of this, which is the research side, the science. As you saw some of the posters out there, I was reading this morning. Some of those posters are great. In that the data coming from there is not just stuff that's being reported to the CEOs about volume and continuous process and improvement, but it's also actually, there's a significant amount of science coming out of that. These are reported in the JACC, in the Annals of Thoracic Surgery, and all the major journals, the Journal of Thoracic Cardiovascular Surgery. These are publications that are coming out of the STS National Database. As Donna showed you, some of the work being done by those workforce chairs and task force chairs that she put up. And so this is very, very important. Device surveillance. As you know, we've had a radical and revolutionary change with the TBT database. The STS National Database will also be a part of this. There's other areas within cardiac surgery. These are kind of the new opportunities that we're going to be seeing rolled out in the next 5 to 10 years regarding left ventricular assist devices, regarding aortic surgery, as we talked about, regarding device surveillance at the FDA and with Medicare and even with insurance companies. So these are some of the new areas that are going to be that are very important regarding the health and outcomes for care in our country. So regarding the new areas of CT surgery, we're focusing mostly on what we do, and as Dr. Sheehan and others have stated, about 80% of what cardiac surgeons do in the United States comes under the umbrella of about 7 or 8 procedures or variations of those procedures. But there's more and more trend towards other procedures, like I just said. And so the STS database is alive. It's a living document. It's a living piece of work, and we will be getting into those areas for a whole bunch of reasons, including quality itself. So I just want to let you know kind of that slow progression as we go through and continue to define cardiac surgeons and what cardiac surgeons do. One of the things that's near and dear to my heart, because I am a thoracic aortic surgeon, mostly anyway, is the new thoracic aortic section. And I just think I wanted to let you know that there's unbelievable areas for improvement. You saw those 3 slides I put up there regarding mortality rates going from 3.5 to 1.5%. Well, that isn't the case in thoracic aortic surgery. Okay, we're talking about mortality rates that are up in the 10% range, and for cases like this, which is an acute aortic dissection, not too long ago it was the 30-30 club, 30% mortality and 30% stroke rates. So with the data that we're going to get out of this new section, and that's true of LVADs and other sophisticated and maybe more sophisticated procedures that cardiac surgeons are doing more and more frequently, is that the data, the outcomes now are not as good as they are for CABG or aortic valve surgery. And so we're going to there's room for massive improvement, and that improvement's going to be coming from this group and the data that this group provides to us. So I just wanted to kind of put that out there at the very beginning as a show. So I want to thank you, but I also want to talk about this slide. Okay? So this slide comes from Philadelphia and is the 2 major paintings. This one's worth maybe 150 million. This one's worth about 80 million. And they're from Thomas Eakins. And one of them is the Gross Clinic. This is Samuel Gross, who was the original surgeon and founder of the American Surgical Association. And you can see it was painted in 1878. It was actually painted a little bit before that. It was painted for the centennial of the United States, which was in Philadelphia in 1876. And this is the Agnew Clinic, which is right next door. This is at Jefferson, and this is at Penn, University of Pennsylvania. And this was 10 years later, 1888. And what you see here is here's Samuel Gross, this big professor. He's in his top coat, and there's no lister. You got this is an amputation, and there's horrified spectators, and there's 4 orderlies keeping this patient down. There's no anesthesia, there's no antisepsis, and there's no nothing. Okay, and I would suggest if you like the kind of the glory and beauty of surgery, you should go see this painting. It's sitting in the Museum of Fine Arts right now because it's a lot better than this picture shows. There's all kinds of blood. I mean, it's really cool. Okay, so anyway, this picture here was painted by the same guy, can see him, here he is, and there he is a little later. Okay? You can see this is only 10 years later. So Lister and antisepsis have arrived. Everybody, the team is in white. There's the short coat medical student is giving anesthesia. The pontificating professor is up, not even doing the operation. He's kind of hanging out. The chief resident is doing the operation. This is a mastectomy, and he is going to be in 25 years. This is the first professor. This is the third professor. We have a nurse. See, first time we have a nurse, and you notice the symmetry. Okay. So, we have only one orderly, and he doesn't seem to be paying attention to the operation too much. He's paying attention to something else. So there you go. This is only in 10 years we have this huge quality improvement, and I think we can do it here too.